And to now introduce our moderator, but also tell you about some great upcoming Friday programs, please welcome your Vice President and Program Chair, soon to be your President-elect, the Chief Marketing Officer and Vice President for Public Affairs at Pepperdine University, Rick Gibson.
Well, thank you very much. We're so delighted to have you here today. I'm confident this is going to be an interesting panel and a great discussion, thought-provoking to say the least. And I want to thank John Lockhart for putting this together and working so hard. And for next week, I want to make sure that you know about what's coming up May 18th right here at the California Club. Another situation very similar to this, where we're going to continue as we make our way to the home stretch of our program this year, issues and answers as we deal with some vexing and pressing issues that are part of our community. And so next week, we are looking forward to a conversation around fire preparedness and prevention. There are those who will say that fire, as we have noted it in the region recently, is becoming more of the new normal as our environment changes. So how do we prepare for that? How do we prevent that? How do we, as a community, get behind the resources that we need for that? So next week, that will be May 18th, California Club. It should be a full house. We're looking forward to that conversation. Also, I want to let you know as we continue to round out the year with upcoming issues and answers, we've invited the next two guests, and I have to tell you, I don't know what keeps you up at night, but I'm about to tell you what keeps me up at night just a little bit. We have two fascinating guests that are coming, but they have a sort of a caveat to their appearance. They need flexibility, they say, because of the nature of their work, and so they've just given me a heads up that several things could call them away, but right now, we're very excited that Dave Jones, who is the Insurance Commissioner for the state of California, will be joining us on June 1st, right here at the California Club. And then David Wright will be, who is the General Manager of the Los Angeles Department of Water and Power. You probably know that Mr. Wright is the General Manager of the largest public utility. So it should be a fascinating conversation with both of those as we begin to wind down our year. So more about that as the day approaches, but I wanted to give you a heads up about what was coming to LA5. Today, I am delighted to welcome our panel, and they'll be making their way to the front here in just a quick moment. This is probably a topic, we already had a little bit of a conversation earlier in the year with Tom Prisilak from Cedars-Sinai, but this is an important and challenging topic for us, and I know we're going to dive deeper into it. We've allowed some time for Q&A, so I'll move very quickly and introduce our moderator, who has asked me, please, Rick, please give me a very short introduction. I'll just simply say that not only is he a legal expert and a lawyer, he is the co-author From Obamacare to Trump Care and Why You Should Care. And he is part of, as Cherie said, Nelson Hardiman, a law firm focused on healthcare. He's going to guide the conversation today, and he's going to introduce our panelists. So would you please give a warm LA5 welcome to our moderator today, Harry Nelson.
Thanks, Rick. It's great to be with you. While I'm just going to make a very brief introductory remark, if I can ask our four panelists to come up, Andy, Joe, Shaw, and Scott, that would be great if you guys can. I don't want to rush your lunch, but since we only have a little bit of time, that would be wonderful. So it's great to be with you. I have to be honest, this is not only my introduction to LA5 for me, but also to Rotary, and it's really a thrill to be with you. I want to thank all of you for having us, and I want to thank John Lockhart for having the vision to put this event together. John has been tirelessly working to bring the business leaders together and to bring new ideas together. And I'm excited to be moderating today because we have a fantastic panel. In just a minute, I'm going to ask them to introduce themselves, but just to sort of talk about how we're going to use the time together, what I'd like to do is have a conversation not only about where we are in healthcare, what's up with healthcare, but also where we are in Los Angeles. We're lucky to have with us the CEO of Good Samaritan Hospital, Andy Lika, and as well as the Chief Medical Officer of California Hospital Medical Center, two of the key institutions that are really on the front line of taking care of the community, not just in Los Angeles, but really as you walk out of this building. We also have people who are really visionaries, and I'm not trying to be exclusive in saying this, but both Shah Godzian and Scott Kaiser working on the front lines of both behavioral health and a next generation healthcare and what that looks like. So without further ado, we're going to dive in. I'm going to ask each of the panelists just to give us a brief introduction about their job, their organization, and sort of their perspective to frame our conversation today. Andy, if I can put you on the spot.
Good. Thanks, Harry, and thank you for this nice invitation from LA5. My name's Andy Leek. I've been at Good Samaritan. We were founded in 1885, so we're in one of the oldest hospitals here in Los Angeles. I've been here for about half those years. And it's, I think what differentiates Good Samaritan Hospital maybe from other hospitals, there are about 14 hospitals in downtown Los Angeles, so it is a well-bedded community. Most of these hospitals operate at about half capacity. I think our real niche for this downtown community is we really specialize in what are termed the more acute services, tertiary care. We have large heart services, large orthopedic, one of the largest retinal repair centers west of the Mississippi. And just to kind of end on a note, I think for me, the challenge is putting together a team that can deliver the type of care that you would want your mother or father to receive at a hospital. So it can't just be that technical, and believe me, we have the best of the best technical equipment in there from cath labs, DP labs, but it has to be delivered with a lot of dignity, with a lot of access, and it's got to be affordable as well.
Thanks. Joe, can I ask you to do the same?
No, sure. All right. Hi, I'm Joe. Thanks again for all having me here. I'm the Chief Medical Officer at California Hospital Medical Center, and like Andy mentioned, we are one of the other hospitals. We're actually down in South Park, right about 2 blocks from the Staples Center and LA Live. Similarly, we are part of the Dignity Health System. We're about a 40 hospital system in California, Nevada, and Arizona. We have been here quietly for over 130 years, serving the community. So as the Chief Medical Officer, I interact with the executive leadership team and I have oversight and responsibility for ensuring the quality and safety of the care that we deliver to our patients every day. And more so, I think, as we get into it today, it's not just the responsibility as when the patients are in our doors, but actually before they come in to our hospital and after they leave, making sure that they have a safe place to land and they're plugged back into the system. Because I think, as we'll talk about a little more, we have a very, very challenging population. Even though we see all of this growth, we still have a very, very challenged community to the south in our primary service area.
Yeah, please, Scott.
Well, thank you all. It's a pleasure to be here. So I'm Scott Kaiser. I'm a geriatrician and the Chief Innovation Officer at MPTF. So as you can imagine, I spend a lot of time answering the what, the where, the what the heck is that, right? So a geriatrician obviously is a physician that specializes in the care of older people. MPTF, the Motion Picture and Television Fund, we've been around about 100 years. Started by Mary Pickford, Charlie Chaplin, Douglas Fairbanks as a relief fund, a safety net for people, the men and women working in the film industry, and that's what we do today. For people working in the industry, we're there as a charitable organization. We act as a safety net through a variety of health services, social services, and financial support. And my role as the Chief Innovation Officer is really to think about a population health strategy for that community, the men and women working in television and film.
Shaq.
Thank you, everyone, for your invitation. My name is Dr. Shah Godzian. I'm the founder and CEO of Clinics on Demand. Clinics on Demand was started as a response to the national and local opioid and overall substance abuse epidemic that we are in the middle of now. It was started actually right when we were in the cusp of it, and right now we're at the what we hope is the peak. So the program is based on delivering substance abuse disorder treatment to people anywhere in the country at any location, at any demographic population, delivering it directly to them at their house rather than having to travel anywhere to receive treatment. So this is particularly important for people in rural areas, for example, who don't have access to treatment, or people in even urban areas who wish a more convenient type of treatment for substance use disorder.
Terrific. Thanks. So, all right. So I want to jump in. We had a conversation last week with the panel, and three themes came out that I hope we're going to cover in our time together. First, one is about this concept of social determinants of health, which I'm going to ask. We're going to have a conversation about, and how the nature of how we treat people has changed over the last decade, and examples of that. Another topic that you can't talk about healthcare without talking about the problem of unaffordability for all of us, and particularly the growing disparities. And the third theme that came across that I hope we'll really dive into is the need for more access to behavioral health and how we deal with the opioid crisis. And so these are kind of the big three topics. Certainly you could have this conversation and spend time on, and maybe we'll have time if people have questions about the changing nature of healthcare consumers, patient expectations changing, cost pressure as we sit 6 months before the midterms, a political uncertainty and how you deal with that, technology. There's no shortage of, we could be here for 6 lunches. But so before we get into the specific topics, I just wanted to take another minute. Dr. Kim made a reference specifically to some of the challenges of the local population, and I think each of you, particularly Andy, Joe, and Scott, you have sort of unique perspectives on what the unique challenges of the LA, Los Angeles, the downtown market, and the Los Angeles healthcare landscape looks like from that differentiated. And I'd love some thoughts if you can share on that question. Yeah, please.
I'll jump in. So it's a huge challenge. What a mixed population. Here we have the regentrification of downtown Los Angeles taking place with 60,000 residents now living down here. 500,000 residents drive into downtown Los Angeles every day. And if you look over by South Park and other areas, you'll see cranes in the air. So there's another 40,000 online. If you look at that demographic, these are the wealthiest of the wealthy. There's a higher per capita income downtown Los Angeles than there is in Beverly Hills. 43% own dogs. I mean, it just goes on. And so this is these are all of you that raise those millennials out there that are really difficult to please without gourmet dinners and everything. Those are the folks coming through our emergency department with a homeless population here in LA County that is now 57,848 homeless, and you've seen the escalation in this. So if you just head east to us and go over on 5th Street, 6th Street, Gladys Street, Wall Street and so forth, from Midnight Mission to Fred Jordan Mission and so forth, those are also the patient population that we have to care for, and they usually converge, if it's emergent, in our emergency department. So, you know, we won't go into too many things clinically, but they're different needs. They're just different needs with this population, socially, physically. You know, just healthcare has been neglected with certain numbers of these individuals versus some of them can walk in with their PPO insurance anytime they want and forget the $4,000 co-insurance or deductible with that. It's affordable to them. Of course, the free care through an emergency department we are required to take. Anybody can come into our emergency department, seek services, and we do deliver them and do a great job. But, you know, different expectations with that. The only thing I'd end on is I would say something. Our homeless are, I think, some of the most sophisticated homeless in the country. They've been to medical school because, you know, when they come in, the first thing, you know, usually they'll do is say, I'm having a stroke, I need opioids, and they'll go down the list with the printout of all their medications and everything else in order to stay out of the misty rain this morning. We'll see a surge. In the very hot weather, we'll see a surge. So we not only just take care of them medically, we clothe them, we feed them, we try to get them back into the right setting.
Joe, on the same point, so at California Hospital Medical Center, you told me something that blew me away, that as a level 2 trauma center, you're seeing more trauma than LA County, which I always thought of as a front line. Any other sort of thoughts about the challenges of the local community?
No, sure. Well, I'd clarify about the trauma. We're probably the number 2 volume of trauma in LA County, next to USC County. That basically means we see more trauma than Cedars and UCLA combined. But as far as what Andy was mentioning about our community and what's going on, I think really what's going on in our backyard in this community is really a snapshot of what's going to happen and what's happening with healthcare right now. That we have a 3-tiered system. Essentially, you have the well-insured, insured, the underinsured, which is the bulk of the population, and the completely uninsured. And you just look at the statistics of what's going on in Los Angeles, in downtown itself. You can be blocks away, and that can determine how long you live, how access you have to green space. You know, it was very interesting. I was reading some research before I came here, and I have to admit, I live on the west side. I live in Santa Monica, where there's probably a fresh pressed juice spot on every block. I think in South LA, less than 10% of adults have access or eat their recommended number of fruits and vegetables. There's half the number of green space in downtown LA as in the west side of LA. So I think it's a very significant challenge and disparities. I think just as much as our hospital needs this community needs our hospital.
Scott or Shaw, any other thoughts?
Well, you know, as I was listening to Joe, you know, he painted the picture of the tale of 2 cities here in downtown LA, and with that, you know, he pointed out in our past conversation the vast disparity in life expectancy. As a geriatrician, longevity and life expectancy is something I think a lot about. So within just small areas, drastic differences in life expectancy. And so what accounts for that is that's where this idea of social determinants comes in. You know, as the physicians on the panel, we'd love to think that it's all like an episode of ER and somebody comes into our emergency room, get the paddles, you know, shock them, and we saved them and we fixed them. But it doesn't really work like that. It's these social factors that really account for the vast impact on people's well-being and even their mortality, right? It's how they're eating, exercising, where they're living, the kind of relationships they have. For me as a geriatrician, it comes down to things like having a sense of purpose in your life. Social connection has more of an impact on your health than smoking 15 cigarettes a day. It's as dangerous for you. Being lonely and isolated is as dangerous as smoking 15 cigarettes a day, right? So it's these social determinants that are really accounting for that difference. It's not genetics. It's not clinical care. I mean, they have these great medical centers right here serving the same population. It's the social factors. And that's really revolutionary. Our system isn't geared to reinvest in those social factors. So it's causing a major disruption and rethink of the whole system.
So one of the things I always worry about when we have conversations like this, we're now 8 years into the Affordable Care Act, and we heard about this shift from volume to value-based care. We heard about population health. If you ever go to healthcare conferences, there's always buzzwords. And so social determinants is very important, and it's something that I think, one of the things that a goal I wanted to set is to make sure that we dug a little deeper. So Scott, if I can ask you, Scott, to start off, and I'd love to hear from the other panelists after Scott, on this question of social determinants, can you give us some specific examples of what you're doing at Motion Picture that actually to address these social determinants?
Yeah, so I mentioned, so there's the kind of hard social determinants about education level and housing and finance, but let me start with the squishy stuff, the hard stuff, right? So let's go back to the social connection thing. So I'll give an example. I have a patient who was coming to see me, and this guy just wouldn't engage in his health care at all, out of control diabetes, out of control blood pressure, just on a crash course for a stroke and heart attack. And it became very clear that one of the issues was that he just had a completely fractured family life. He worked in the television and film industry. He was on set 18 hours a day, traveling all around the world. And he just had nobody to talk to. So we rolled out a program called the Daily Call Sheet, where we train industry volunteers to just make social calls to people. And he started getting a call through the Daily Call Sheet. And it came out that he hadn't talked to his daughter for 30 years, right? And through that conversation, they said, you know, he said, you should do something. You should reach out to her. There's no time like the present. He said, you know, I'm in my 80s. I could have a stroke any day. There's no time at all. He reconnected with his daughter. He met his grandkids for the first time. Believe me, that guy coming in to see me in the clinic, he manages his diabetes. He manages his blood pressure. He's on a completely different course. So that's just the kind of story where we can try all day to do things that are geared to increase medication adherence or reduce hospital readmission or reduce avoidable costly emergency room care. But really, until we dig into what's driving people and what's driving the behavior and what matters most to people, we're not really going to be able to move the needle.
Thank you. Does anybody else want to share examples of social determinants?
Yeah. I mean, I think exactly. Thanks for bringing up the tale of two cities. I mean, even as an individual clinician, I still see patients on the west side of Los Angeles, and someone can come in with a very different, same symptoms, but a different etiology. Take headache, for example. Patient on the west side, I don't know if I'm going to be able to refinance my loan. I think I might be getting divorced. How's your blood pressure? You've been taking your medications? Have you been exercising? Yeah, I try to swim and try to go to. I didn't get to the gym this week. I'm really stressed out. I'll be in my teaching clinic, and you'll have the resident who's very, very academic. Wants to work up stroke. Is this patient having cancer? And you can just simply ask, when was the last time you ate? And the reason that these patients have headaches is because they have food insecurity. They just don't have access to food. And I think that really kind of struck it for me as well, that this huge, things that we take for granted are things that our patients in this community are dealing with every day.
Do you want to share a little bit about the Hope Street Margolis Center?
Sure, yeah, very proud and very happy to be affiliated with that. The Hope Street Foundation started as a relationship with UCLA about 30 years ago. They had a staff of 3 serving 120 underserved families that just kind of happened to come through our hospital. Today, we're happy to say that they have a staff of about 150 serving 5,000 families, and they serve a variety of services, family services, early childhood education, family planning, family literacy, job counseling, healthcare literacy, getting them plugged into social services. We were very happy to find out that one of the first children that was actually born in our NICU has actually that graduated through the program, has actually went on to medical school, is now an anesthesiologist, and is working at one of the area hospitals. So it's one of the real success stories and just a real jewel in our community benefit program, and really creating that connection between the hospital and the community we serve.
So Shah, if I can put you on the spot, I'm just curious, as somebody working in telehealth, focusing on behavioral health, do social determinants, is there a strategy or way that you see it playing out in your work?
Yeah, I think exactly what Scott, Joe, and Andrew were saying is that when you look at physical health, the emotional, psychiatric, behavioral health of a person is a direct determinant of their physical health. And I would say that if you look at, if you ask Andrew and Joe about their patients coming in to California Hospital and Good Samaritan, they'll probably tell you a lot of them are coming in because they have an underlying behavioral or mental health issue that was not addressed, that then caused some sort of physical health issue. And one of the underpinnings of this is substance abuse disorder, unfortunately. So treating that, and treating that in a convenient type of a fashion, which now telehealth allows us to do, is really going to be a guiding principle of healthcare moving forward. That we are able to provide healthcare to people at their convenience, at their location, to improve their health and hopefully prevent the recidivism rates and the revolving door of the ERs that we see, for example, in downtown LA. And again, one of the unfortunate issues now is the substance abuse epidemic, and how do you treat it, and how do you treat it for patients who are homeless and people who do not have means, and how do you treat it inexpensively, because it is a very expensive problem to treat right now. So how do you do all that? And you know, my money is on telehealth, being able to provide that on a somewhat of a concierge basis at a much reduced cost structure than ever before possible, even at an even higher quality.
So one of the things, by the way, I loved about this panel that John helped put together was we really have a striking contrast in different approaches. Telehealth is certainly a key part of the solution, but obviously there are many problems that can't be addressed on the ground. So I kind of wanted to pivot to the topic of healthcare unaffordability. I asked the panelists if they had questions they wanted to answer, and Andy gave as clear a question as you can ask. You know, why is healthcare so expensive in the U.S.? And I wanted to ask the panelists, beyond telehealth clearly is a big part of the answer, but not only why is it so expensive, but how do we actually address these problems beyond social determinants? Other thoughts about the problem and the solution?
I don't know. You know,
Ditto.
yeah, we're playing around with a system where the various players in this aren't acting together. I mean, they're not acting as one for the patient's health. So you can start out with an employer who passes money on to an insurance company, who passes money on to a hospital, who passes money on to physicians, pharmacy benefit, and everything else. Ambulance companies, we've got SNFs, we've got everything in there. And everyone, but everybody, is really trying to maximize their potential within their organization. So it's not a single payer system. We don't have universal health care here. It's, you know, Singapore is 1/6 the expense here in the United States with better outcomes. We can go through all of those examples, but I try to simplify things in problem solving, and so I go back to All the President's Men, you know, in 1976 when that came out with Bob Woodward and, you know, being portrayed in there, and Carl Burstein, and they started talking, oddly enough, about this attorney, Liddy, you know, and other things in there. And, you know, one of the lines in the garage eventually was, just follow the money. And that's what you need to do, because I will tell you, from my perspective, the money is in the system. It's just what we're doing it with the money. And so there's this inequitable distribution of the money across the board, as there is with social determinations of who's going to get what. And I believe that, you know, this audience probably wouldn't figure out that, and Joe, not to pick on you, but since Tom isn't here, we'll pick on Cedars, right? that's how this works in this game, doesn't
That's
it?
good, yeah.
California Hospital and Good Sam, man, aren't those great hospitals? So you look at this picture, and the same mom coming through the emergency department with the same insurance, any one of you can come through our hospital and with the same physician, and we will take into another hospital in a community for the same insurance, will earn 300% of what we will earn. None of you can believe that. You're all, well, you all have the same insurance and get the same amount of money. The answer is no. There are all of these layers on top of it. Pharma right now has the largest lobbying group in all of Washington, D.C. There's like, I don't know, 750 lobbyists in Washington, D.C. just for the pharmacists. So everybody's taking and trying to rake the money back. And when the rules work in your favor, you don't want them to change. When they don't, you're trying for a new bill out there. But I don't know, personally, Harry, I've always thought, I said this to Harry before, I think the smartest guys in healthcare, the smartest guys out there is those guys running ambulance companies. because they have figured out every trick in the book of how to scam things all the way across the country and everything else. So my solution for solving this, it's just like hackers, you know, that you hire these hackers that have gone to prison or whatever to come in to start working with the government to find other people. I'd hire the ambulance driver people, those companies, to say, we'll give you $100,000. How would we game this system? And I think those guys are so smart. They're so brilliant that you get right to the bottom of it.
Any ambulance company operators in this Rotary?
Not in this crowd.
Okay.
Yeah.
All right, you guys heard it here first.
Yeah.
Any other thoughts?
Yeah,
on...
I mean, I'm with Andy. I think that the misaligned incentives, but I think that the blame is really, there are a whole myriad reasons that you can come up with why healthcare is so expensive, and people like to debate back and forth that it's one or the other. It's pharma, it's the hospitals. I think it's all of the above. But just to kind of go with one of the issues again, with this misalignment of incentives, you take a program like MPTF, we have a palliative care program, which is just an absolute lifesaver for so many people. It takes care of people with serious illness. It's not just for end-of-life care. We have people who are actively trying to beat their cancer, going for concurrent curative treatments. Actually, 60% of our census is actually trying to beat their disease using palliative care. But palliative care is a service that's really centered around the patient's goals and the family's goals. And we do that by bringing in a team that works together. So there's a chaplain, there's a social worker, there's a team coordinator. You need that whole team to be able to navigate the system and to be able to deal with all of the issues, medical, symptom management, personal, financial, existential, that come up when you're facing serious illness. And so at MPTF, we pay for all of those wraparound services through raising charitable dollars. There's no payment mechanism to be able to pay for all of that great care that benefits people and actually reduces costs in the end. It's, the only thing in a fee-for-service system, we bill for the physician time. And it's not even that great a payment for that, right? But so that's where there's plenty of money in the system, but it's not necessarily going to where it would best serve patients and families.
But I think that we're in a real, very interesting and very exciting time of change that I don't think we've seen anything like this before, where we're seeing the model of healthcare change, and it's changing towards more of quality outcomes and lower expenditure. And this is the goal for everyone, and it hasn't always been that way. We see these changes having started probably about a decade ago, and we're in the midst of it. So from the types of programs that are being, that are out there now that didn't exist before, for example, more palliative care programs, more hospice programs that weren't there, more community-based programs, such as Joe was alluding to, more telehealth programs now. All of these are now, they're not competing, they're converging together to try to raise the quality of what we're offering people, improve outcomes, and lower the cost, which everyone at the end has to pay. And this is across all lines of care, whether you're talking about medical, behavioral, mental health care. All of them are going through this transition right now.
I'm curious, I had a conversation before, and I think a lot of people in the room as employers are wonder about the role of, is the solution, did the solution come from the government? Is the solution, we're now entering the approach to the midterms in a gubernatorial race in which issues like California going to a single payer system with more government oversight, or whether, and I had a conversation earlier about whether employers are really a driving force. I'm curious if any of you have any thoughts about that push-pull between where the solutions to healthcare unaffordability and better care are going to come from.
Well, for us, we work with a lot of employers who want to reduce their cost for healthcare. And so they see telehealth as a big driver of that. of reducing their costs and improving quality. For example, for us, we provide services for substance abuse treatment at 1/5 the cost of traditional models. Think about that. At only 20% of the cost that the employer was paying before. But our outcomes are 4 times better. So for us, the employers were a big driver because they came to us and they said, we need something. We got to have something better for our employees. There's a small subset of our population, of our employees, that are using behavioral health services, but the amount that they're paying, that they were paying, was huge. So they're looking for better outcomes. So that they are a very big driver.
Yeah, I mean, probably, I agree with what you're saying about the exciting time that we're in, lots of opportunity, but I temper it by the fact that so much of this is still the exception, not the rule. While we've had an explosion in palliative care programs universally are struggling to figure out how to get paid. So within this context, I'd say, I mean, it's an amazing time. Think about Amazon, JP Morgan, what was the third?
Berkshire Hathaway.
And Berkshire Hathaway getting together to figure out, we've got to solve this problem. We've got to figure out, I mean, that's a team I'd love to be a part of. They've got a few resources, you know.
Just had their shareholders meeting, so you may wait till next year.
But what's really striking is kind of in the healthcare, health services world, there are a lot of people writing about, talking about, thinking about how they won't be able to do it, that they won't be able to make a dent, which is amazing to think about the magnitude of the problem if it's something that Amazon, Berkshire Hathaway, and JP Morgan can't dig their teeth into and make a difference. So,
yeah, I just comment here. This isn't insurance that people have. This is, you know, this is when everything collapses in your system. You know, this is catastrophic insurance, and they'll dress it up by calling it, you know, a skinny plan or something like that. You know, people have better car insurance at times than they do health insurance in this room. It's not working, and it's getting worse. 40% of the population of the United States don't have $2,500 to afford to go in their first $25 off the top, much less their co-insurance. You know, and those plans are being squeezed down actually so people don't go in. I mean, if you got the first $4,000 out of pocket to go in, I wouldn't exactly term that preventative care. That's catastrophic care. And when you come into Good Samaritan Hospital and, you know, you've got your insurance card there and it's $4,000, who's going to take the hit on that? So let me tell you how this works. Medi-Cal patients, Medicaid nationwide, we get about 77 cents on the dollar. So the other 23 cents we lose on every Medi-Cal patient coming through the door. Medicare for our seniors, about 85% coverage. We lose about 15 cents on each patient coming through the door. Homeless, that's 100%, okay? And so you in this room are left with your employers or being self-employed to offset that loss. Your health insurance of $1,000 a month, $12,000 a year on average across the United States, it's just cross-subsidization of what isn't working in the first place. And even now with the commercially insured population, that's called bad debt. In a hospital, it's called bad debt. So here's the game that's played with doctors. The doctors, they're so damn smart. They're just, these doctors are so damn smart. What they do
not
is...
as smart as the ambulance.
Yeah. That's true. Then we'd be king. What they do is they let the hospital send out their bill first, and the hospital, you know, just craters on the $4,000 deductible, and they'll hold off a few months before that's kind of finalized, and then the docs come in once the co-insurance deductible has been met. That's how smart doctors are. Joe, that is. So
I wish I knew that.
Yeah. So you see how this system, even within the system, it's being gamed. Yeah. It's going to come down, I think, that we have the first chance, at least for a single payer system, probably coming up in the next election. I would tell you, it depends on who gets in office.
So I'm curious to hear from the rest of you, how do you prepare for that? You and your organizations, are you thinking about the prospect of single payer? And more broadly, how do you deal with the political uncertainty of this moment in time? We're 16 months into an administration which has been chipping away, and it's not clear how much the Affordable Care Act model of the health insurance exchanges and the employee, the subsidization is going to last. We have a lot of uncertainty. We're still going to be 6 months out from the midterms. How are you and your organizations thinking about how to move forward in this environment?
I mean, a lot of uncertainty is an understatement, right? I mean, it's just complete uncertainty. And I think there's such, the fact that we might have an opportunity for a single payer system in California is incredible, but there's so much misconception, confusion, lack of understanding about what that would mean. I mean, there's a whole wide array of single payer systems across the world. So it doesn't mean just any one way. But, I think we're at MPTF, we're in a little bit of an unusual situation because we're a charitably driven organization anyway. So amidst the uncertainty, for us, we just kind of keep our head down, keep investing in the services that we know make a difference for people, and just fight on. So.
Any other thoughts, John?
And I went to USC for a minute. Knew that would be a crowd pleaser.
For us, fortunately or unfortunately, it's actually quite different because there is now more money being funneled on the both state and national level into behavioral health, substance abuse services, and mental health services than ever before possible. For example, Medicaid now, who typically, as Andrew was saying, is the worst payer you can have, now pays actually pretty decently for people to go to residential treatment centers. So, and then what you hear about on the national level, you see that there is supposed to be an influx of money into this, into the behavioral health realm. We haven't seen that happen yet. We've seen a lot of money go into research, actually, in pharmaceutical research. We haven't seen much money go into new forms of treatments like we're doing here. But on the behavioral and mental health aspect, actually now is a good time to be in it. I think once we get into a single payer system, it'll be really interesting to see how what the parodies are going to be between mental health and physical health treatment, which has traditionally been very different.
By the way, just one comment. As you think about single payer, I would encourage people to think about the real battle that we're going to have as that idea, which has support in the state, goes forward, is between a model in which everybody is forced into one payment system, or alternatively, a universal access, universal coverage model in which employer groups that are self-funded and that are really managing their own workforce healthcare are allowed to exist in their current form, and then we worry about everybody else. So that's a big divide that's important to think about. It's not a all or nothing conversation, and that has big stakes for anybody who's an employer.